Good afternoon. I'd like to thank everyone for joining the Transplant Institute lecture series today. I'm Kelly Collins. I'm one of the abdominal transplant surgeons here at Henry Ford and the Children's Hospital of Michigan. And it's our pleasure to have Michelle Jesse here to speak about the caring for the caregiver with her work from the Organ Transplant Caregiver Consensus Conference. I'd like to remind everyone to please mute your mics throughout the presentation. Dr. Jesse is a clinical health psychologist and clinical investigator who has been on staff with the Transplant Institute since 2013. She's currently the director for resident research within the Department of Internal Medicine and an adjunct research scientist with the Center for Health Policy and Health Services Research at Henry Ford. She is a clinical assistant professor within the Department of Psychiatry and Behavioral Neurosciences at Wayne State School of Medicine. Within the American Society of Transplantation, Dr. Jesse currently serves as the chair of the Psychosocial and Ethics Community of Practice and chairs the Organ Transplant Caregiver Initiative, and she was recently awarded status as a fellow of the American Society of Transplantation. Her research interests focus on access and disparities in healthcare, optimization of psychosocial factors in both patient and patient caregiver groups in organ transplantation, and clinical provider wellness. Dr. Jesse and her 3 beautiful children and husband enjoy good food, hiking, travel, and look forward to being able to travel again in the future. Thank you, Dr. Jesse, for presenting today. Please type any questions you may have into the chat function, and we'll address these as time allows at the end of the presentation. And again, please mute your microphones during the presentation.
There we go. Thank you, Dr. Collins, for that lovely introduction. Again, I'm Michelle Jesse, and today I'm presenting on Caring for the Caregiver report from our Organ Transplant Caregiver Consensus Conference. I have no conflicts of interest to disclose. However, funding for the Organ Transplant Caregiver meeting was generously provided by Novartis, the American Society of Transplantation, the Society of Transplant Social Workers, the Henry Ford Transplant Institute, the International Society for Heart and Lung Transplantation, NATCO, the Organization for Donation and Transplant Professionals, and the National Kidney Foundation. First, I'd like to acknowledge my collaborators. These types of efforts cannot be done in isolation, and so I'd like to thank each and every one of them for all of their contributions and their tireless efforts to work on this project. And also our caregivers who contributed in valuable ways throughout this entire process. We've had some really, really terrific caregivers who have across the country and continue to have caregivers engaged in this process. So whenever I present, I always like to give a bit of an outline so that folks know where we're going and how this is going to go. So first, I'm going to give a general introduction to caregiving. And we're talking about informal or lay caregiving. Now, sometimes I'm going to comment on the broader caregiving literature, and that's because sometimes there aren't adequate empirical literature in the organ transplant caregiver population. So when I'll try to be careful to note that when I'm talking more about meta-analyses or systematic reviews in other in other chronic disease models such as cancer or stroke or dementia. Then we'll talk about caregiving in organ transplant specifically. We'll talk about how the Organ Transplant Caregiver Initiative came to be and what we did, and then I'll leave you with some next steps and recommendations. So first, an operational definition. What is a caregiver? Well, a full-time multitasking ninja is a good way to put it. So again, these are lay caregivers, informal caregivers, family caregivers, however we want to use those terms. They're an incredibly heterogeneous group that care for an incredibly heterogeneous population of patients. So there's been a lot of back and forth in the social literature about what a caregiver is. And there's two main factors that are consistent across caregiver groups. And that is one, these are individuals with no financial or contractual obligation to provide care. And they provide care in the patient's social environment. So that's the only universals we've got right now as far as what a caregiver is. And given the varying roles and resources they provide, that's not terribly surprising. Now, within the United States, nearly 1 in 5 adults are estimated to provide care for another adult in any given year. So that's quite a lot. Now, within these individuals, a quarter report difficulties in coordinating care. A fifth report their own health is not optimal. So in other words, you have someone who is not doing so well themselves, caring for someone who's not doing well either. And almost 50% report significant financial impacts. Now, to put this into context, there's significant costs of caregiving. Caregivers are estimated to provide the astronomical sum of $257 billion in unpaid services every year in caregiving. Now, that's double the cost of home health and nursing home combined. So in other words, this is the cost they cover. But this doesn't include what they actually spend as well. So current estimates would suggest, on average, caregivers spend around $7,000 out of pocket. Now, this includes these kinds of, so factors that come into this is loss of wages and associated facilitating of care. But what that is in organ transplant, we don't really know. We don't know right now. So a very important topic in this construct is caregiving burden. So in other words, what is the impact of caregiving on the caregiver? And just like defining what a caregiver is, this is a difficult construct to define. And the two universals are that caregiver burden is aspects of caregiving that adversely impact the caregiver's physical, financial, social, and or spiritual functioning, and that it encompasses both objective and subjective elements. So again, going back to the costs, financial costs, we can objectively measure time off of work, loss of wages, but there's also the worry and the strain and the stressors associated with having to care for complex patient needs and how that impacts the individual in an interpersonal sense, in their relationship with religious or spiritual factors, but also it can be very physically burdensome. And I'll talk a little bit more about some of those physical burdens shortly. Now, this within the broader caregiving literature. So in other words, not specific to organ transplant because we haven't looked at this adequately yet, but in the broader caregiving literature based upon, again, meta-analytic and systematic reviews, these are some of the consistent contributors to negative outcomes for both caregivers and patients. So in other words, when the patient or when the caregiver has a negative outcome, the patient is more likely to have a negative outcome. So some of these factors include sociodemographics, being a female caregiver, and in particular, being a female caregiver to a male care recipient, lower socioeconomic status, and living with the care recipient. Also, the higher demands of caregiving. So someone who, for a patient who maybe is less ambulatory or less able to care for their activities of daily living, the higher the demands of caregiving, the greater the burden. The next one's an interesting one because this did come up anecdotally in a number of our caregiver groups, and that was the perception that they did not have a choice in becoming a caregiver. So in other words, when the individual feels like, well, that's all they are, and that's the only option that the patient has is I have to be their caregiver. That significantly contributes to negative outcomes in the broader caregiving literature. Greater perceived care recipient suffering. So this is typically a family member, or a friend, or someone that has an existing relationship. So when they see more pain and suffering, that creates greater burden. Not surprisingly, limited social support, but also a home environment not conducive to caregiving. So for example, if you have a patient who was historically ambulatory, but lives in a dual-level house, and the only bathroom with a shower or bathtub is on the second floor, and they lose their ability to navigate those stairs, that's significantly burdensome on both the patient and the caregiver. Now, it's not all bad. Now, admittedly, burden is definitely the more prevalent when we look at burden versus benefit. That's been consistently found in the broader caregiving literature. But caregivers do report benefits across a number of domains. So for example, they report personal growth from the experience. They may report that they have a greater awareness of what they were capable of and are able to do certain things that they didn't think they could do before. They may report greater spirituality. They may report greater closeness with the patient and being happy that they could help their loved one and or friend through a difficult time. So there are benefits to caregiving as well as burden. Now, to give a little context, it's always good to give context. So I've talked generally about caregiving up to this point, but what's relevant here is organ transplant is different than other chronic disease models. It's different than dementia, it's different than cancer. because we have this established evaluative process for our patients to get to organ transplantation. And per CMS and other organ-specific guidelines, transplant candidates are required prior to listing to have an established social support. Now, with that in mind, this requirement, while for good reason, for good and appropriate reasons, to ensure that the patient has the necessary resources and support to navigate the process and to live successfully with organ transplant, it does place a great deal of burden and responsibility on the caregivers in the patient's life. And so it's important, it's important to note that level of that infrastructure, if you will. And it's also important to note that too, that we've heard caregivers indicate an additional pressure from this because they felt that if they didn't step in, whereas maybe they were able to step in to some extent, but hadn't planned to step in quite as aggressively as we quote unquote require, they were aware that the patient wouldn't be listed and couldn't get transplanted, and which ultimately could mean a death sentence. And so there's an additional nuance to that in the context of organ transplantation. Now, admittedly, this varies. The specifics of the requirement for social support and caregivers varies across centers. But again, so recognizing that this does place an additional layer on our caregivers is of value as we move forward. So, as a result, there have been increasing calls for engaging caregivers as stakeholders in organ transplantation. Each chronic disease model has unique elements, and transplant is no different. While the general elements, and even within transplant, there are general elements within transplant that are universal or generalizable, if you will, across organs. There's also very specific factors within the organs or across the organs that can significantly contribute to the caregiver experience. So, for example, MCS in heart transplant or mechanical circulatory support in heart, or hepatic encephalopathy in liver. So the specific nuances of some of the presentations of the patient and the types of care they require does impact the caregiver, as do the more general concerns of, being uncertain about on the wait list, of concern about whether or not the patient's going to do well with the transplant, and how long are they going to live, and how long is the graft going to live, and what is their increased risk of cancer and infection control. And so there are these unique challenges that are worth noting in the context of what we ask our caregivers to do. So, where did this all start for me in this process? Well, it's interesting to note that in 2017, the American Society of Transplantation held a patient summit. And what was really fascinating was at the summit, there was a psychology breakout session, which was led by my friend and colleague, Sheila Jauzi-Gregor. And even though the questions were pretty broad in the sense of saying, what do patients and caregivers feel that they need in the context of organ transplant that maybe we're not providing enough of, the pervasive theme was, we need more for our caregivers. So in other words, when given a broad opportunity to respond to what do you think you need the most at this point that you're not getting, and they said, we need to help our caregivers. So that was very powerful. And so in early 2018, the AST Psychosocial and Ethics Committee of Practice began a caregiver initiative. I was co-chair at the time, and I, myself and several colleagues began to put together a general outline of what can we do? Where are we going to go with this? And so we started to have calls for collaborators and stakeholders, including organ transplant caregivers themselves. And throughout 2018 and 2019, we developed and refined our objectives. What are we trying to accomplish? What do we want to do? Well, first, we thought, okay, we have to understand what we do know now. So we wanted to summarize current knowledge on benefits, burdens, and best practices. In other words, we wanted to have an idea of what we do know about the caregiver experience in organ transplant and what we know based on the empirical literature and somewhat experientially about what is the most effective in helping our caregivers navigate this process to both mitigate negative outcomes, but also encourage positive ones. We also, one of the main themes was we have to create a comprehensive educational toolkit, a resource. Within the American Society of Transplantation, there's the Living Donor Toolkit, which we think is great. We wanted to model it against that, but we also were very interested in some of the cancer, the format and the structure of some of the cancer, like National Cancer Institute, caregiving resources. They have very dynamic, interactive, comprehensive caregiver focused educational toolkits. And then we, and then we wanted to say, okay, what do we need to do next? So we want to develop this educational resource. We want to review the research, and we also want to say, okay, this is where the research needs to go next to really progress this knowledge base and to help our caregivers throughout this process. Of note, I wanted to make a note at this point to another discussion topic that evolved over time was we decided we would focus on caregivers to adult transplant populations. This is not because we don't think child populations are not very important, but just because it required such a different level of separate consideration that we felt that was something that we needed to do separately. And so there are discussions of that moving forward. So in mid-2019, we were awarded funding for a consensus conference. We were very excited. Novartis decided to fund us, and there's a number of us. It's not everyone, but as you can see, Dr. Collins and myself are in this photo. In this photo, there are caregivers, there are social workers, there are research scientists, clinicians, and just a really great group of people. Again, this isn't everybody, but that was a number of us that were at our consensus meeting, which was held October 6th and 7th, 2019 in Dallas. Thankfully, we got it before we couldn't have it in person. And over the course of 2 days, we had 16 presentations. So through our meetings from 2018 to 2019, we continued to focus on content areas and where we needed to focus our energies and the themes that emerged. So through these discussions, basically 8 main themes emerged, which became work group focuses. So we ended up with 8 work groups across generalizable content and then organ-specific content. So as you can see from the work group focus, one was logistics and process issues. So how to navigate the transplant process, FMLA and legal protections for caregivers, things of that nature. And then obviously caring for the patient was a huge element. How to take care of yourself as the caregiver and your quality of life. And then additional considerations, which included things like spirituality and the impact of culture on organ transplantation, or sexuality and reproductive issues, things that didn't perfectly fit in the other work group focus. And then obviously 4 work groups on the kidney, pancreas, mechanical circulatory support, heart, lung, and liver. A few notes here. We did decide to include MCS because so many of our heart transplant candidates do have mechanical circulatory support. So we included that as an element of the heart group. If you'll notice too, there's not multivisceral or some of the other emerging transplants. That was because we are aware of a caregiver resource within multivisceral transplant, or was being prepared at the time. So we decided we would potentially partner with that in the future. Now, within each of these 8 work groups, each work group was tasked with 2 things: to review the empirical body of research across everything that could be considered within that work group focus or content area, and then make initial recommendations regarding possible research priorities to fill in the gaps wherever the research had gaps. And then from an educational standpoint, we were all directed to, or the directives were to review all existing publicly facing educational content, and also, if willing, to share any content that was developed by the individuals in the work group that was shareable, and then review experientially through both caregiver report and clinical provider report, all topics of possible education for inclusion. So at the actual meeting, we had 16 in total, since every group had 2 presentations, one on research, one on education, followed by discussions. And these were video recorded. So what did we find? Well, as we said, first our objective was, let's summarize the burdens, benefits, and best practices. And here's what's really astronomical. Reviewing the empirical literature within organ transplant caregivers, over half of organ transplant caregivers report high levels of burden based upon established clinical cutoff. Now, this range actually goes from 50 to 80%. That's clinically significant. That's not just statistically significant, that's very clinically significant. So in other words, the vast majority of our caregivers report a great deal of strain in their caregiving role. And those domains of burden generally fall across three main domains: lifestyle, patient well-being and care needs, and the impact of caregiving itself. So they reported, consistent with the broader caregiving literature, they reported lifestyle changes, financial concerns, and work-related adjustments. They also reported considerable concern about the patient and the progression of the disease and the patient's suffering, feeling the need to ensure that the patient's mood was kept up and that the patient didn't become depressed or more depressed. And then the impact of caregiving. So there was quite a bit in the impact of caregiving that was specific to organ transplants, but also general. So again, uncertainty, unpredictability of the future, physical strains, neglecting their own needs. Within the specific organ systems, things like hepatic encephalopathy was a huge contributor in the liver patients. Within heart patients, it's worry about the pump and the pump performance. In certain lung groups, it was worry about trachs. So there were definitely some organ specific as well that all fell within these three main domains. Now, when we look at caregiver burden and outcomes in caregivers and in patients, there is a relationship. Now, but it's not linear. In other words, caregiver burden does not predict caregiver mental health and then predict patient outcomes. It does, but it's not linear. So in the sense of saying caregiver burden does contribute to caregiver mental health, caregiver burden does impact patient outcomes and other patient or other caregiver outcomes. Now, this is based upon, again, this is a step back and saying we didn't find a lot in this domain in organ transplant, unfortunately. There was actually really small amount, in particular with regard to how caregiver burden or caregiver mental health affected transplant patient outcomes. There was a little bit in heart transplant, mechanical circulatory support and heart transplant that would suggest that caregiver burden and caregiver mental health may impact survival in heart transplant. But other than that, we really didn't find much. Within the broader caregiving literature, it's pretty well defined. Well, again, not linear because these tend to interact over time, is that greater caregiver burden does predict greater mental health risks in caregivers, and that includes depression, anxiety, mood disturbances, sleep disturbances, and of note in particular within organ transplantation, some transplant caregiver groups experience post-traumatic stress disorder. So due to the incredible, unpredictable, and sometimes very frightening way that some of the illnesses progress, these have real significant impact on our caregivers. Now, within the broader literature, again, these outcomes, so I should put that the caregiver mental health and outcomes, this does include morbidity and mortality in both patients and caregivers. Again, we need to parse that out a lot more in our caregiver population. But again, it wasn't all bad. So there were benefits. And the two main benefits we found in our caregivers, based upon the empirical literature, were largely patient related. So having the time to spend more time with the patient, providing the patient support. And one consistent theme was the gift of transplant and a second chance at life. And then personal growth, again, similar to the broader literature of caregiving growth and greater faith, hope for life renewed, discovering one's own inner strength, really refocusing priorities, feeling loved and wanted and needed. So there were perceived benefits as well as some of the burdens. So what do we do with best practices? Well, we don't know. Those are my daughters. So unfortunately, we scoured the literature for how do we best care for our caregivers, our organ transplant caregivers. And the truth of the matter is there's not a lot of direction. There's not a lot of research. There's very little evidence empirically supporting how to best, or very little empirical evidence telling us how we can best support our caregivers. What's important to note with interventions and interventions in education for caregivers is targeting them. In other words, in the broader caregiving literature, it emphasizes that there are thresholds of interventions that are maybe assumed by the designer to be helpful, but in some cases can actually be harmful. So for example, there are thresholds in education that for some individuals are, oh, that's good to know, whereas for another individual, it could increase stress and hypervigilance. So for example, we in designing some of the education, which I'll come back to, a caregiver said, well, I wish somebody would have told me my husband could have had steroid-induced psychosis while he was in the ICU. And now for that individual, maybe that would have been beneficial for them to know. But for some individuals, what the broader caregiving literature would suggest is that information in some individuals, like I said, would only increase hypervigilance if it's not a real significant increase in risk. Now, within the broader caregiving literature, there are a few consistencies based upon meta-analytic data that suggest that caregiver education, comprehensive caregiver education on the patient's condition and expected trajectories, does have a moderate effect size on burden. So education is essential and we should never get rid of it. We should just be thoughtful about how we provide it. Other treatments, but unfortunately education does not have a significant effect or has a small to non-significant impact on things like depression or anxiety. Again, going back to that nonlinear burden to mental health outcomes. Now, other treatments such as cognitive behavioral therapy and mindfulness have small effect sizes on things like depression and stress and burden. But really, the broader literature has recommended that multi-component interventions have the strongest effect sizes when we want to examine burden and other negative mental health-based outcomes in our caregivers. Now, what's interesting about that, however, is that what combination of interventions and at what dose, if you will, or threshold we provide those combinations has not been clarified. So we don't know, in other words, we don't know if 8 weeks of CBT with 8 weeks of mindfulness and comprehensive education is more impactful than 4 weeks of CBT and mindfulness and education. Or if we need to include mindfulness at all or CBT at all, or if some combination really reinforces the effect sizes. So our second objective, as we said, was to create a comprehensive educational toolkit. And there's the unofficial table of contents. I'm excited to report this beast is written. She's over 80 pages long, which I am very length. It's not necessarily quantity; it's quality. So with that in mind, one, because everyone had contributed, I'm sure it is very quality. I've read it through it already, but we are vetting it thoroughly. So these are basically the work group focuses that we originally proposed with some modification. And we included a section on caregiver resources because there are some general federal level or state and national level resources that are really great, like the Caregiving Alliance as an example. So really reputable, strong resources that we can provide additional links to. So like I said, we are vetting this thoroughly to ensure that this is a high quality resource that is both comprehensive and generally accessible. I mean that in the sense of content across groups. So in other words, so that it's easy to read, its health literacy is at an appropriate level, that it covers the major points, that it doesn't incite anxiety but provides information or directs the individual to the appropriate information, etc. So right now we have a group of 8 new caregivers that are reviewing these sections. So these are individuals who have not been previously involved in our process. So coming at this with fresh eyes. And then next it will go to 16 transplant social workers through the Society of Transplant Social Workers, who will further vet and review the content. And then after that, then it goes to the AST board, and it will be seen by their board and their education committee. And then once they approve the content and all the links, and we go through a lot of the legal aspects, then we are already in discussion with how we want this to appear through the AST and other websites. The idea being that it will be a standalone website in the future, but with obviously links to the American Society of Transplantation. So in other words, some of these might be translated into video, some of these will be available via PDF, some of these will be available potentially in other formats, And we are also in discussion for translation. So for example, we have several individuals who have been involved and are continue to be involved who are bilingual and are bilingual Spanish speaking. We've also had discussions with the National Kidney Foundation looking into translating into Arabic. Anyone who's developed an educational tool or any translated any tool knows that you not just translate, but you back translate. So there's a whole process of that. That's another layer of complexity. But the point being is that it's going to be the most useful resource we can possibly make it to be when it is released to the general public. We hope that it does come out sometime next year. So what about research? So that's obviously where my focus often lies. And what we found was we basically through a ranking system. So first off through thematic analysis of the meeting itself, we outlined every comment or discussion on a research theme that was needed in the literature. And then we clustered the thematic content and eventually came down to a list of research priorities, which we then sent back to everyone who was involved, including the caregivers, and everyone ranked the research priorities. And we went through this process a few times just to make sure we were tapping on the right items and the themes were consistent and we weren't overlapping. And really what came out as the highest research priorities is we still don't have a great understanding of the impact of caregiving on our caregivers. There is a good body of literature that's given us a great start, but we really don't know what are the negative impacts of caregiving on the caregiver. There's some really nice benefits of caregiving from Jim Rodriguez and his group in particular and some other individuals, but we really don't have a good understanding of caregiving, the impact of caregiving on the caregiver, such as loss of income, loss of wages, loss of income, loss of work, the emotional burden. And, we know they are at increased risk for depression and anxiety and even PTSD. But we don't know how that trajectory looks clearly in our caregivers. One is, again, going back to what I said previously about validation of educational content, something we've been very thoughtful about. And I know our center here with the Transplant Living community has always been very thoughtful about is thresholds of education, but also timing of education and the amount of education you give at any given point. So in other words, we don't have good data on when, it's not a good idea to give somebody this manual. I wouldn't recommend this. I would recommend saying, here's this big, thick manual, read that. They're probably not going to read it. And if they do read it, because of some of the emotional distress, they're not going to absorb the information adequately. So we have to validate in the sense of when is the best timing, what is the best format, and what is the best content to give to provide education to help with both patient and caregiver outcomes. And similarly to both the above, prospective methods examining predictors of outcomes for caregiver and caregiver patient dyads. In other words, we have very, very, very little literature that's examined the caregiver patient dyad. In this domain, I reference a lot to cancer because cancer is a bit further along in this regard. And so there have been some factors that have been found in caregiver patient dyads that actually impact both the caregiver and the patient. And there's some interventions that have been shown to improve survival. So caregiver interventions, psychosocial interventions that improve survival in cancer patients. So in that regard, so that's a big area. And again, we have to understand the temporal elements of the demands in our population first and foremost, so we can understand those predictors of outcomes. And there are more, which are all in our meeting report. And then a fourth discussion item came up. In other words, we had these three objectives. We were having these wonderful conversations, but a fourth theme emerged that we felt very passionately was worth noting and needed some discussion. And that was advocacy, and particularly across two domains. So in other words, anyone who works with caregivers and patients, knows, for example, that FMLA is often significantly limited for our caregivers. It is a wonderful job protection resource, federal job protection resource. However, once FMLA has been used up, what is the caregiver supposed to do? And then also FMLA does not protect pay. So in that sense, they can take the time off of work and not lose their job, but in some cases that doesn't keep the money coming in as far as groceries and mortgage and other types of income-related issues. So there are some real limits to what our federal protections are for our caregivers in the context of organ transplantation. And so one of a big theme there was we need to do more both at the state and federal level. Now, what's nice about our toolkit, educational toolkit, is because we had so many wonderful social workers, they have outlined links to basically the federal FMLA website, but also state level resources. So some states do provide pay in the context of these roles, but those are variable and dependent upon the state. And so we genuinely believe, because of the unique nature of organ transplantation, that these should be federal level policies. Related, a second area of advocacy was for better funding for research, and particularly directed research. Now, these two are related because how can we provide support for a federal level policy without evidence of the need for the federal level policy? So again, these are interrelated, and this is something we're going to start to discuss more and more. But it was just a really interesting sub-discussion that emerged, and we realized we have a fourth objective. And so we need to start thinking about this and talking about how we can help our caregivers move forward. So some of our next steps. So one, our meeting report has been accepted for publication in the American Journal of Transplantation. So if you'd like to review what I'm presented on today, most of it is in there, including, like I said, in the supplemental materials is a comprehensive thematic content of research priorities. So that's one exciting development. Education. So as I said, we are at this point where we have this beautiful educational resource, but once we vet it and it goes live, that's not the end. As we know, transplant is an ever-evolving domain of medical care. And so it will require ongoing updating. It will require ongoing verification of accuracy. And also, as technology progresses, ongoing development of interactive formats. So education will be an ongoing process. As we said, with research. So we have a number of actually projects that have come from this collaborative effort. We decided to do a systematic review on interventions engaging caregivers to organ transplant patients, and that we have a current manuscript that's being circulated amongst the co-authors. We hope that is ready for publication by the end of this year, and it reiterates what I said previously, that there's very little, and what has been done is very preliminary, and most of it's feasibility or exploratory rather than full clinical trials, rigorous methodologically clinical trials. And advocacy. So one of the things we did right now, because many of us were like, what can we do for advocacy? How do we advocate for our caregivers in this regard? So we contacted the American Society of Transplantation and their political advocacy arm, and there's going to be some webinars coming out to sort of teach us how to get the boots on the ground, so to speak. In other words, what can your average clinician do to encourage and facilitate advocacy in this domain? And some of that is just talking. In other words, some of that is just having the conversation amongst ourselves so that this is on people's bandwidth, including our policymakers. So there's going to be, that's sort of shaping up right now, but that's one of our major areas of discussion, and always welcome to engage additional individuals who want to collaborate on that front. And this is not the end. That's where we are right now, but the saga continues. Again, education is an ongoing endeavor. Research is an ongoing endeavor. We have a lot of research to do. We have a lot of education and resources we need to work on providing, but the saga will continue. And just because the Organ Transplant Caregiver Initiative has met its initial objectives does not mean that the individuals involved or myself are anywhere near stopping. So like I said, several of us are collaborating on one grant, and we have another grant in the pipeline right after that one. And, so we're also discussions regarding how we can transition into the pediatric realm. And again, in pulling in some of the other organs that maybe, or transplant systems we didn't necessarily cover at this point, such as multivisceral. So the saga does continue. So important for those of us at Henry Ford and those listening is that, within Henry Ford was optimally positioned to take the lead on this. And that is largely on the shoulders of giants. So the transplant living community obviously was much of the concept and direction, the transplant living community is obviously an essential giant in that domain and very unique to our center. Of the multitudes of individuals I've spoken with and collaborated with across the country, it is a very unique resource, and we are very lucky to have it, as is the Patient and Family Advisory Council. So I encourage folks to get in touch with Patty Magyar if interested. I think, feel free to contact me, but I think, again, this is an in-house opportunity and an example of a really successful couple of programs that put Henry Ford steps ahead of other centers. And on that note, I will say thank you so much for listening to my presentation today, and I welcome any questions folks have.
Thank you so much, Dr. Jessie. That was wonderful. Again, I'd like to invite people to type any questions you have into the chat function, and we'll try to vet as many as possible given the time constraints. We'll start with a question from Dr. Venkat. Should caregivers be formally evaluated pre-transplant to ensure that they are not being coerced into caregiving and that they have a realistic understanding of the skills required for what they are committing to?
That is a very pertinent question. And actually, that was a comment. That's a great question. And very early on, we got into the discussion of what our objectives were and whether we were going to tiptoe into the requirements regarding caregivers. In other words, how we evaluate and how we select caregivers. And there, I'm afraid I'd like to say we have a really good answer, but we don't have that at this point as far as the caregiver evaluation in relation to patient outcomes and caregiver outcomes. We just don't have the empirical support. But that's exactly what we mean when we say that's where the research really needs to go direly. I think it is worthwhile, and again, unique to transplant is that caregivers are part of the care team, as we said, because that's the context, right? The way we require social support makes the caregiver an essential part of the care team. And so there is that question of option and choice. And are they the patient? Are they part of the patient? Are they part of the healthcare team? What is their role? And so in that sense, we do have this really, novel sort of interaction that is very unique compared to other chronic disease populations. So I wish I had a better answer from either an empirical side. Clinically, I think that the theme, while we did get into this a little bit, we were very thoughtful about it, again, is whether or not, we're talking about evaluation of caregivers. Just like with our patients from a psychosocial standpoint, one consensus we did agree was that the evaluation should be about ensuring that the caregiver is optimized. Again, and meaning if there is some kind of identified barrier to the caregiver effectively performing their role, then it's in our best interest and their best interest and the patient's best interest to try to figure out how to address that. Now, it's difficult because, again, these aren't the patients. So that it was a conversation, and my answer is, yeah, we're going to work on that one.
Thank you. Dr. Abbotsford asks, should we be designing our own interventions for caregivers?
Yes. In fact, that's what one of the grants coming up is right now. So going back, the R21 that I'm working on is a caregiver intervention, and it's a multi-component caregiver intervention applying a novel methodological framework, which will allow to sort of isolate aspects of the intervention to look at that. So yes, I think we should. Is there the specific empirical support is again from the broader caregiving literature would say education is necessary. So I would say everything the TLC and the team does is very good. But I think what the TLC has done and the team has done very well is be thoughtful about the content. In other words, again, there's just being thoughtful about the content in regards to not stimulating increasing anxiety in some people versus providing adequate information. So I think it's a delicate balance in that regard. As far as other things, caregivers do report benefit from support groups. They report benefit from, other types of engagement. They've reported, there's one of my collaborators, and I believe this publication is nearing press, so I can say this, but so she had she intervened on an increased access to a specified nurse coordinator for some education and found some pretty significant effects. So the one thing about burden or caregiver burden and caregiver outcomes we also want to keep in mind is burden of participating in interventions relative to burden of caregiving. So we have to be thoughtful about that as well. And I think that's what I mean when I say we have a lot of work ahead of us on making sure we're optimizing these interventions.
Another question, COVID has added another level of complexity when dealing with caregivers. And maybe that you could comment on things you've heard through the care group or otherwise, but what are some creative strategies, in your opinion, that we can implement to address the needs of our patients' caregivers during this additionally stressful time?
Well, I will say too, actually, what's interesting is we didn't originally have an emergency preparedness portion in the toolkit, which we do now, thanks to COVID-19 and some other discussions. So I think that, yes, I think that we have this really unique and special novel interaction that we can optimize on. And in some respects, technology in this caregiving population is ideally suited to address some needs, potentially. So for example, when we've ran analyses on our patients and their caregivers, and they live all across the state, right? They live all over the state. They live, anywhere from 1.5 miles away to 200 miles away. So some of these technological interfaces allow for these caregivers to potentially interact with either other caregivers or with providers in ways that would not have been feasible before and that we wouldn't have been as aggressive in exploring. So in some respects, COVID-19 has really sort of motivated some of, including funding entities, on validating some of these interfaces to encourage some of these interventions. And so in that sense, that's actually been a positive direction in the long-term care of our transplant patient population. So even though it's not an intended there's no intended outcome, but in the sense of saying, like, if we can push these technologies farther and improve them faster, and the COVID-19 has motivated some of the regulatory groups to support this more aggressively, then that's good for us in the long term, we think. But we're gonna have to test that.
Beth Rubinstein asks, could the psychosocial assessment for transplants that's been validated, like the Stanford Integrated Psychosocial Assessment for Transplant, IPAT, be adapted or distilled for screening caregivers or comprehension testing throughout the process and stages of transplant?
That's an interesting one as well, because the other thing that the SIPAT what the SIPAT cues in my brain, which was a discussion item, was insurance. In other words, again, we had a great group of social workers who knew this 7 ways to Sunday. With SIPAT or any evaluative process is the provider, we always have to talk about provider reimbursement or, care reimbursement and things like that. So the SIPAT, there's a lot of insurance companies that will not reimburse for that as a testing instrument, which a lot of people don't realize. So in the sense of, like, when the psychologists have even talked about implementing it, it's kind of been a little bit of a dead end because it could be that, again, our reimbursement for it is really low. And that's largely because it's kind of predictive of outcomes, but it's not the strongest it could be. And again, that goes back to sort of a selection bias, which is a whole other conversation. But again, the same theme is consistent when we're talking about evaluating our caregivers and saying, what are the SIPAT is a general broad instrument with several subsections. But the question is what, if any, elements of a caregiver are predictive of outcomes, positive, negative, or otherwise, or caregiver outcomes.
I love this because I think it reflects the influence of TLC here at Henry Ford, and that Dr. Venkat questions, do you think we could use past caregivers in educating a future caregiver?
Yes, I do. I think that's great. I think that the TLC has set, I think in the broader caregiving literature, peer-to-peer support has a small effect on a number of bad, negative outcomes, if you will, so like burden and mental health. However, one of the interesting things is that peer-to-peer support is often rated the most high by caregivers, as in the aspects they appreciated or enjoyed. So even if, again, going back to those multi-component interventions, like in other words, the current recommendation suggests multi-pronged approaches, but peer-to-peer support is really one of the highest rated ones as far as preferences are concerned. So yes, I think that, caregiver, just like the TLC model, same infrastructure, same system type of format, that would be potentially very well liked by our caregivers and our patients.
Thanks. And then I'll just ask a question for myself. Do you think that there are ways that everyone on the team can sort of add into our vocabulary or the way that we approach our patients to make sure that we're recognizing or acknowledging the caregiver burdens without, I think sometimes we shy away from it a little bit, and that we may open a Pandora's box that we don't know necessarily how to solve the problems are. But I don't know if you have any recommendations for how we can begin to engage in that discussion.
Absolutely. Yeah. I mean, some of this for me was stimulated by a number of when I've done clinical care in the past. There are a handful of caregivers that I'll never forget because, quite frankly, from a mental health standpoint, they needed the mental health resources. They were the ones that I was like, I'm not assessing you, but I can, I feel the anxiety coming off of you. So I think that, I'm trained in mental health, but I think that for those of us who are in the day-to-day care and not, having a limited amount of time, I think that's what these resources are all about. So one is referring the caregivers to the transplant living community. Again, in the NPFAC, I think that those are, we're so lucky to have that and utilize that. So if we get a sense that they are struggling or that they are in need, then continue to encourage them to the TLC. In the near future, we hope to have this caregiver toolkit as well, which will be linked again to a number of national resources. So in the future, again, providing them, as soon as we get this go live, providing the link to the American Society of Transplantation caregiver toolkit. It will also be on the Power to Save website. And then, like Venkat said, maybe we, work on some peer-to-peer advisory groups. That would be potentially really interesting. I think, like I said, it's given the complexities of these patient populations, you all have a lot to focus on already. And so I think that it's at this point, it's really about connecting them to the resources that could be helpful and useful to them. And in some cases, that does mean saying, I know Kelly Bryce and some of the other clinical psychologists and social workers provide, monthly support groups. So like I said, so sometimes if you get a sense, then point them to those resources and encourage them to engage them and encourage them simply to, in order to be a caregiver, you have to care for yourself first.
All right, well, we are pretty close to time here. I want to thank Dr. Jessie again for her wonderful presentation, for everyone for joining in. Please feel free to reach out to Dr. Jessie with any follow-up questions, and have a good remainder of the afternoon.
Thank you, everyone.